channel. In this video, we will be learning about chronic leukemias, which are the chronic myeloid leukemia and chronic lymphoid leukemia, CML and CLL. Yes, your blood is full of hard-working cells. But what happens when some of them start growing out of control? Let us begin our journey in the bloodstream. CML, chronic myelogenous leukemia. It's a blood cancer that starts in the blood-forming myeloid cells or stem cells in your bone marrow. There is no age limitation. At any age, it can affect, but mostly adults. CML represents about 15% of all types of leukemia. It takes long time for CML to get worse. Maybe you have this condition for years before noticing the symptoms. Many people learn they have CML after routine blood checks. Prompt treatment keeps CML from getting worse. Before going deeply into CML, we need to know what is leukemia reaction. It's only a reactive process which mimics leukemia. It won't be a malignancy. It's due to different stress events such as infections, hemorrhages, inflammations, or other malignant disorders that has a similar presentation to CML. Let's take a look at the comparison between CML and leukemia reaction. Of course, we need to go to peripheral blood sphere examination. Then in CML, it will be left shift, same like in leukemia reaction. Also, left shift will be there, but it will be mild. In CML, neutrophilia, eosinophilia and basophilia will be there, but in leukemia reaction only neutrophilia, absence of eosinophilia and basophilia. In CML, dysplastic features will be there. In leukemia reaction, toxic changes are often present. See the toxic changes. Toxic granulations will be there in cytoplasm. In CML, WBC count will be like 20 to 500,000 into 10 raised 9 per liter, but leukemia reaction it won't be like that. It is more than 60,000 cells per liter, almost 50, 55. It's like that. Platelet will be increased in CML, but in leukemia reaction it will be normal. Anemia present in CML. Leukemia reaction is absent. Lab score low in CML, lab score high in leukemia reaction. Of course, Philadelphia chromosome will be there in CML, but it is absent in leukemia reaction. What are the causes of CML? People with CML have an acquired genetic mutation or change in myeloid stem cell growing in their bone marrow. It will be acquired. It is not present at the birth. That means it is something you are inheriting after your birth. Acquired mutations happen during your lifetime. In genetic mutations, mutated genes means it's a changed gene. Its properties are changing. These mutated genes give cells new instructions on what to do. Like a computer or a robot, our instructions are already programmed. When this mutation happening to the genes, the program will alter. In this case, the mutation creates new fused gene, BCR-ABL. The new gene triggers the following chain of events that lead to chronic myeloid leukemia or CML. How? The BCR-ABL gene gives new instruction to myeloid stem cell. The stem cell make an abnormal version of tyrosine kinase enzymes. Usually, these enzymes helps to manage cell growth. They act like on and off switches. Here, the abnormal tyrosine kinase enzymes don't have an off switch. Without an off switch, what will happen? Myeloid stem cells in your bone marrow divide and multiply uncontrollably. Over time, abnormal myeloid stem cell in your bone marrow start dividing and multiplying uncontrollably, making unusually large amounts of immature white blood cells. It's blast. Slowly, the blast accumulate in your bone marrow, making it hard for your bone marrow to make normal cells. Normal cells means normal red blood cells, white blood cells, platelets. You may have fewer red blood cells but more platelets and abnormal white blood cells. That means this accumulation of blast will block the bone marrow to do its function properly. See the chromosomes, how the Philadelphia chromosome is forming. Most people with chronic myelogenous leukemia have a chromosome called Philadelphia chromosome. Inside their blood cells, normal cells contain 23 pairs of chromosomes. Everyone knows We have 23 pairs of chromosomes that are made of DNA. DNA holds the instruction for every cell in the body. The Philadelphia chromosome forms when chromosome 9 and chromosome 22. Chromosome 9 and chromosome 22 break and exchange their parts. This creates short chromosome 22. See the normal chromosomes here in the picture, you can understand. Normal chromosome, this is chromosome 9, this is chromosome 22. There should be a break happening in the case of CML. See the chromosome 9, this part is breaking. For chromosome 22, here see this long chain is breaking. For chromosome 9, this short chain is breaking. Then this changed chromosome 9, see here, this chromosome 22 coming and attaching to the chromosome 9, same like chromosome 9, this short part is coming and attaching to chromosome 22. This changed chromosome 22, it is known as Philadelphia chromosome. The Philadelphia chromosome forms when chromosome 9 and 22 break and exchange parts. This creates a short chromosome 22 and a new combination of instructions. These new instructions can lead to the development of CML. Gene formed when pieces of chromosome 9 and 22 break off and exchange their parts. The ABL gene from chromosome 9 joins to the BCR gene on chromosome 22 to form BCR-ABL1 fusion gene. The changed chromosome 22 with the fusion gene on it is called the Philadelphia chromosome. The BCR-ABL1 fusion gene is found in most of people with CML and in some people with acute lymphoblastic leukemia or AML. The resulting chimeric BCL-AB1 gene resulting in uncontrolled cell growth. What are the clinical features of CML? It mostly affects older adults and rarely occurs in children, though it can occur at any age. Up to 50% of cases, the diagnosis is made incidentally from a routine blood checkup. Symptoms related to hypermetabolism means weight loss, lassitude, anorexia, night sweats, anemia will be there, splenomegaly, bruising, epistaxis, menorrhagia or hemorrhage from other sites because of abnormal platelet function. Then, which are the stages of CML? Chronic myeloid leukemia is characterized by an excessive proliferation of non-functional leukocytes. We already explained. So, there are three phases: chronic phase, accelerated phase and blast phase. Okay. See this picture. This is a normal adult blood vessel will be like this. All the cells are equally distributed according to the allowed limits. The chronic phase remains generally asymptomatic, almost 5 to 6 years. It will be asymptomatic. That time, the percentage of blast cells in our bloodstream is 5%. See the dotted lines. This is dead. The chronic phase remains generally asymptomatic. During this time, 5% blasts are found in the bloodstream. After 5 to 6 years, without any treatments, it's progressing to accelerated phase. This accelerated phase will be like 6 to 9 months and the blast percentage also increasing to 5 to 20%. See, this time the disease is worsening. Chronic phase. In the chronic phase, we did not find out the patient is having CML. Yes. Without any treatment, this chronic phase is worsening and is going to accelerated phase. Same like blast percentage also increasing from 5% to 5 to 20%. It will be like 6 to 9 months. Then it is going to final stage, blast phase. The term itself we can understand, the blast percentage is increased. It's more than 20%. Symptoms also will worse. It's almost 3 to 6 months. The chronic phase is going to accelerated phase. In the accelerated phase, blast percentage will be 5 to 20% and symptoms including fatigue, loss of appetite and weight begin to appear. Without treatment, it will become worsen and the accelerated phase progresses to blast phase in 6 to 9 months to the blast phase, causing rapid deterioration of the general condition of the patient, and it will become worse without any treatment. What are the investigations and diagnosis? Of course, CBC. Marked leukocytosis, anemia, and thrombocytopenia will be there in CBC examination. In the peripheral blood smear, immature myeloid cells, myeloblasts, promyelocytes, basophilia and eosinophilia will be there. Reduced red cells and platelets, thrombocytopenia is there. See the picture. Next, FISH techniques, fluorescence, in situ hybridization. The laboratory test is used to examine genes and chromosome in cells. See, normal genes ABL1 and BCR is separate. Here in CML, there is fusion of BCR ABL1. The presence of BCR ABL fusion gene confirms the diagnosis of CML. It results from the Philadelphia chromosome, which leads to the formation of active tyrosine kinase. Surface marker changes in stem and progenitor cells in chronic myeloid leukemia. See the normal stem cell. There is surface protein CD34. If it's in CML, look, BCR-ABL and P-stat is coming, then CD93, CD26 and CD25 proteins will be developing. IL-1 RAP also. What's IL-1 RAP? Interleukin 1 receptor accessory proteins. Same like in progenitor cell, normally CD34 and CD38. Here IL-1 RAP also in CML. Peripheral blood film from a patient with chronic myeloid leukemia superventing in idiopathic myelofibrosis. See the picture. Idiopathic myelofibrosis is also called achnogenic myeloid metaplasia or AMM. It's a disorder that causes the gradual replacement of the bone marrow with fibrous tissue. When the disease is progressing, the normal functioning of bone marrow is replacing with someone. Because the body is recognizing the bone marrow is not able to function and proper metabolisms are not happening. The body tries to compensate it by signaling the spleen and liver to create new blood cells. However, the cells produced by this process do not function properly. So the patient is having blood cell deficiencies. It's understood if something is not functioning properly and we are replacing with something else, never it will become like a normal one. See the orange granules. It's a blood film with a patient having chronic eosinophilic leukemia. This one, film of a child with juvenile chronic myeloid leukemia. Juvenile chronic myeloid leukemia, it's mostly for children below the age of 4 years. Chronic myeloid leukemia showing promyelocytes, metamyelocytes, band forms, segmented forms. Now we can go to chronic lymphoid leukemia. CLL is a type of cancer in your blood. It's the most common form of leukemia in adults. Currently, healthcare providers don't have treatment to cure CLL, but they do have treatments to subside the conditions. Several disorders are included in this group and are characterized by the accumulation of mature lymphocytes of either B or T cell in their blood. Either B or T cell, B lymphocyte or T lymphocyte in the blood. It's not clear what causes chronic lymphocyte leukemia, but the studies are showing that it's mostly inherited. Having a close family member who is had it may mean you have a slightly higher risk. What are the clinical features? The mean age at the diagnosis is 72 years with only 50% of cases before 50 years of age. Male-female ratio is approximately 2:1. That means more frequent in males. Over 80% of cases are diagnosed from the results of routine blood tests usually taken for another reason. Maybe patient is going with some fever or some kind of infection. So accidentally it's finding out. Enlargement of lymph nodes. The most frequent clinical sign, the nodes are usually discrete and non-tender. Features of anemia, thrombocytopenia, bruising or purpura. Splenomegaly and hepatomegaly will be there. Immunosuppression is often a significant problem resulting from hypogammaglobulinemia and cellular immune dysfunction. In the beginning stages, there will be bacterial infections such as sinus infection or chest infections. In advanced stages, it will become viral infections, especially herpes zoster and fungal also seen. There are 4 stages of CLL. Stage 0, it has too many white blood cells called lymphocytes. In stage 1, too many lymphocytes plus lymph node are larger than normal. That means lymph node enlargement. In stage 2, the blood has too many lymphocytes, the spleen is swollen or enlarged. This is called splenomegaly. The liver may be swollen. In stage 3, the blood has too many lymphocytes. The blood also has too few red blood cells. This is called anemia. The lymph nodes, liver or spleen may be larger than normal. Platelet counts are close to normal. This stage is at high risk. Stage 3 is high risk stage. Then we are going to stage 4. The blood has too many lymphocytes. It also has too few platelets. Thrombocytopenia severe. CLL and SLL are different forms of the same illness. They develop when B cells that don't work properly. In CLL, chronic lymphocytic leukemia, the abnormal B cells build up in your blood and bone marrow. In case of SLL, small lymphocytic lymphoma, these abnormal cells are built up where? In lymph nodes. That's why it's called as lymphoma. Both are the same disease at a cellular level but differ in their clinical presentation and site of involvement. This is a smudge cell or basket cell. Smudge cell is a common finding in patient with CLL. It's an important question. See, what is TPLL and TLGLL? It's a kind of chronic lymphocytic leukemia. TPLL, it's T cell pro-lymphocytic leukemia, is an extremely rare and typically aggressive malignancy that's characterized by the out-of-control growth of mature T lymphocytes. T cells are a type of white blood cells that protects the body from infections. TPLL affects older adults with a median age and it's more common in men than women. We already discussed these things. What are the difference between TPLL and TLGLL? TPLL, T cell pro-lymphocytic leukemia. TLGLL, T cell large granular lymphocytic leukemia. TPLL, pro-lymphocytic, that means immature lymphocytes. TPLL affects immature T cells, highly aggressive and required urgent attention. It contains large immature cells. TLGL, T cell large granular lymphocytic leukemia. The term itself we can understand it affects mature T cells, large granular lymphocytes. It's slow progressing compared to TPLL. TLGLL is slow progressing, sometimes associated with autoimmune disorders, contains mature large cells with granules. What are the difference between TPLL and TLGLL? In conclusion, the type of cells immature in TPLL, mature in TLGLL, and the level of aggressiveness. See the T cell diseases. TLGL lymphocytes from right-chained cytospin. These cells characteristically have abundant cytoplasm. NC ratio, you see. There are astrophilic granules. When we are focusing, maybe you can see. See the TLGLL, large lymphocyte with granules. Large lymphocyte, there is granules. This is a film of a patient with TPLL showing marked lymphocytosis. Medium-sized prolymphocyte with basophilic cytoplasm and single nucleolus. Some cells with cytoplasmic blebs. See the blebs. ATLL or adult T cell leukemia or lymphoma is a rare T cell lymphoma that can be found in the blood, lymph nodes, skin or multiple other areas of the body. ATLL has been linked to infection with T cell lymphotropic virus type HTLV1, a virus that infects the T cells. It's important. HTLV. It's a virus that infects T cells. This is a picture. Cells have irregular nuclei. See the nucleus. Deeply convoluted. Some cells have nucleoli. Here, a bizarre morphology with convoluted clover leaf nucleus and a constant CD4 plus phenotype. Let's go to B cell disease. It's also same like CLL. Diagnosis made by appearance of a majority of pro-lymphocytes in the blood. High and rapidly rising lymphocyte count. Anemia is having poor prognosis. Splenomegaly without lymphadenopathy. Prognosis is worse than CLL. Here is a leukemia. The term itself we can understand. See in the cytoplasm hair-like projections. Uncommon B-cell lymphoproliferative disease. Here is a leukemia is uncommon B-cell lymphoproliferative disease. It's a mutation in exon 15 of the gene for the protein kinase BRAF underlies the most frequent classical variant of the disease. Patient is having infections, anemia or splenomegaly, lymphadenopathy, pancytopenia, lymphocyte count is rarely over 20. Monocytopenia is a distinctive feature. Monocytopenia, hair-like projections in the cytoplasm. Then Sézary syndrome is a rare fast-growing cancer that affects your skin and blood. Sézary syndrome symptoms may look like eczema or other common skin issues. Sézary syndrome is a rare leukemia variant of cutaneous T-cell lymphoma CTCL defined by the triad of erythroderma, lymphadenopathy and atypical malignancy. What are the diagnoses? CBC. It's a primary investigation. Low RBCs, increased lymphocytes with a significant rise in the number of lymphocytes. Anemia will be there. Sometimes thrombocytopenia. In blood film examination, the presence of immature lymphocytes in the blood which may appear abnormal under the microscope such as mud cells. In flow cytometry, there is increased lymphocytes showing specific markers like CD5, CD19, CD20, CD22, CD23. This characteristic immunophenotype allows a definitive diagnosis. Then, of course, genetic tests fish may show genetic changes such as 13q or 17p, which indicate disease severity. Fish technique, it will show genetic changes, which is the indication of disease severity. See these pictures. This case of CLL, peripheral blood film showing lymphocytes with thin rims of cytoplasm with coarse condensed nuclear chromatin and rare nucleoli, typical smudge cells. See the smudge cells. It's a characteristics of CLL. It's a case study from a patient with CLL. WBC count you can see here. HP is almost normal, RBC slightly decreased. See the MCV and MCH. Platelet is slightly decreased. Lymphocyte you can see here. 94.4% of lymphocytes. You can see the pictures. Abnormal lymphocytes. There is blobs, smudge cells. So in these cases, we will go for further investigations like genetic studies, chromosome analysis. Finally, we can conclude the leukemias. Okay. So that's a quick look at chronic leukemia, a condition that develops slowly but needs careful monitoring and treatment. We can summarize leukemias which we learned in previous classes. ALL, AML, CLL and CML. ALL, in ALL and AML, rate of progression acute. It is fast growing leukemias. In CLL and CML, rate of progression is slow. It's chronic, slow growing leukemias. ALL affected cell lineages, lymphoid cells. AML, myeloid cells. CLL, lymphoid cells. CML, myeloid cell. Chronic myeloid leukemia, myeloid cells. Chronic lymphoid leukemia, lymphoid cells. But the rate of progression is entirely different in ALL, AML, CLL, CML. The difference, acute means it is fast growing, chronic means it's slow growing. Lineage, according to the name itself, we can understand lymphoid lineage and myeloid lineage. Typical age, ALL is mostly childhood leukemia, can occur in adults. AML, more common in adults. CLL, older adults, typically over 70 years. CML, adults typically 30 to 50, it can affect at any age. Common symptoms are mostly similar in all kinds of leukemias. See CLL, in case of CLL, it is asymptomatic in early stages, may include swollen lymph nodes, fatigue, frequent infections, unexplained weight loss. In CML, often asymptomatic in chronic phase, may include fatigue, night sweats, weight loss, feeling full in the abdomen due to enlarged spleen. Enlarged splenomegaly will be there. So always we will feel like abdomen is full. Diagnostic features: ALL, high number of lymphoblasts in bone marrow and blood, immunophenotyping to identify specific lymphoid lineage. AML, high number of myeloblasts in bone marrow and blood, immunophenotyping and cytochemical stains to identify specific myeloid lineage. There will be presence of ORODs in AML. In case of CLL, diagnostic features: sustained increase in mature appearing lymphocytes in blood and bone marrow, characteristic immunophenotypes. In CML, presence of Philadelphia chromosome, BCR-ABL and fusion gene in blood and bone marrow confirmed by cytogenetics or molecular tests. That's all about leukemias. Keep learning and always try to ask questions about the topics. If you found this video helpful, don't forget to like, share and subscribe. Thank you everyone.